In this lecture, we're going to be looking at blood pressures. Lots of normal values, lots of new acronyms, and how these pressures will correspond to the heart function. So the first thing you guys are going to see is this table. So I tried to make a condensed table of all the information that you guys are responsible for the exam. What I would do before you listen to this lecture is write out your flashcards with all of these things on it and try to get savvy about what the acronyms are. You don't have to know, you don't really have to understand this right side here, what the abnormal values mean, because we're going to talk through this in this PowerPoint and in the heart failure PowerPoint. But get familiar with these acronyms so you feel like you know what I'm talking about as you listen to this lecture. So I put them all in one spot for you. Down here you have the equations that you guys are going to be responsible for this exam. These are all the equations that you guys are going to have memorized for this Unit 3 exam. So this is a very important table. Memorize it. You're responsible for the information, and it's all condensed in one place. So we're going to talk about the 4 determinants of blood pressure. Stroke volume, which we talked about, is the volume of blood that's ejected from your ventricles into your lungs and into your body. Vascular resistance, which we have looked at systemic and pulmonary vascular resistance, and this is going to be that afterload, or essentially what blood flow has to kind of work against. Arterial compliance, you can think about compliance the same way that you think about lung compliance. Arterial stretch, arterial compliance. So if you are familiar at all with kind of like when people talk about cholesterol or plaque building up in your arteries, what that can do is it can almost create a stiffening of your artery where it doesn't stretch as much. You could consider it as a low arterial compliance, and that can affect your blood pressure. And lastly, your heart rate. So these are the 4 determinants of blood pressure. This also should end up on a flashcard for you guys. We're going to start with your pulmonary arterial blood pressure. So we really emphasize the systemic circulation and the pulmonary circulation as 2 separate systems that we are looking at. The pulmonary circulation is just the heart to the lungs, back to the heart again. So it's a smaller loop, lower pressure, gravity dependent. So in survey, you guys had to practice taking people's blood pressure, and you probably got pretty familiar with the normal values for a systemic blood pressure. So that's the blood pressure that you're taking on someone's arm. This is your pulmonary artery pressure. So try to think of this as just looking at your pulmonary circulation. It has similar numbering. It has a systolic pressure and it has a diastolic pressure, just like the systemic pressure does. But if you look, these numbers are much lower. So the average systolic pressure for pulmonary circulation is 25, and the average diastolic pressure is 10. So 25 over 10. Your mean pulmonary artery pressure, your MPAP, is 15. These numbers are going to mean a lot more as we kind of move through this PowerPoint, but this is like all good information for a flashcard. I try to condense it down for you. And if you think about this compared to systemic circulation pressures, it's much, much lower. And this is a low pressure system. We've talked about this. It has low vascular resistance because, again, you're just going from the heart to the lungs back to the heart. You have these thin-walled vessels with little smooth muscle. And why do we want these thin-walled vessels? This is our single cell layer thick situation where we are wanting for really good gas exchange. You have blood going into your lungs. Its primary purpose is to pick up that oxygen, drop off that CO2. So we're talking about thin-walled vessels, right? Fragile vasculature, low pressure system, low vascular resistance. The other reason that you want this very low vascular resistance, low pressure system is you have blood that has been draining from your body through your superior and inferior vena cava into the right side of your heart. Right? The right side of your heart is then going to eject blood into your pulmonary artery, and this is the pressure that's reflecting that. You want low resistance to that because you really want to be able to get as much blood as possible into your lung for that gas exchange. So you don't want any resistance. You don't want any high pressure to make it more difficult for that cardiac output to really get into the lung. Because if you have low blood volume on the right side of your heart, it's going to mean that you're going to have low blood volume on the left side of your heart. Because if you can't put very much blood into your lungs, then that means not very much blood is going to come back from your lungs into the left side of your heart. So you really want as much blood as possible to come from the right side of your heart and be able to go into your lungs as easily as it possibly can. All right, you really want that to be a process where there's not much resistance. And again, it's gravity dependent low pressure. It only has to get that blood to the top of the lung. It does not have to shift that blood all throughout your body like your systemic circulation. I have to take a kind of this little side stop that I really wish that we didn't have to do anymore, but it's still on your board, so just bear with me for a couple slides here. We're going to do a really quick kind of like segue. When we're talking about pulmonary arterial pressure, there's this thing called a pulmonary artery catheter or a Swan-Ganz catheter. These used to be used for every heart patient that came back from the OR. It was designed to measure pressures in the heart very closely. It is not used, I don't want to say it's not used at all anymore because, I only work at Gunderson and La Crosse. I'm not saying that you don't see it anywhere, but I would be surprised if it's used really anywhere anymore. And the reason why is it's pretty invasive. It has high infection rates, and they've gone to different methods to kind of achieve the same goal as this catheter. And what this catheter was designed to do is that it could measure central venous pressure, pulmonary artery pressure, and pulmonary capillary wedge pressure. So these are all pressures of the heart, and this could measure that. So it was their way of kind of keeping an eye on a heart patient after a procedure. The reason that I still have to talk to you about this is because you guys take boards at the end of this program. The board is filled with just a smattering of different random respiratory information. It doesn't get updated all the time for all the new processes that we have. So sometimes there's outdated things on there. And this is one of the things that's still in like patient case scenarios and something they're still wanting you to know about. So I want to make sure you guys are prepared for that. So when you're talking about the pulmonary capillary wedge pressure, Pcwp, it's a pressure that's measured in the pulmonary artery. And what it is used to kind of denote is what your left atrial pressure is. The only way that we can kind of gauge the left ventricular pressure is to know the left atrial pressure. So it's like we put something in your artery to measure something else, to approximate something else. Are you confused yet? Because when you think about trying to put a pressure manometer into somebody's heart, right, to measure pressures of the different chambers, you could imagine that there's going to be limitations to that, because by putting a catheter through a heart, you're going to be blocking blood flow, you're going to be creating an infection risk, and you can only kind of feed it into the heart so far before you could possibly damage the heart or have much more risk factors to the heart. So they would put this into the pulmonary artery to kind of estimate the left atrial pressure, which then estimates the left ventricular pressure, because they can't get into the left ventricle with a measuring device. So that is what they were looking at, and you can kind of see it here. So if you can imagine, they feed this catheter in through the superior vena cava into your right atrium. Oh, sorry, this is a better one. Into your right atrium, down to your right ventricle, up through your pulmonary artery, and then this balloon sits right here, okay? And what it does is, as this is feeding through, it has like this almost EKG-like reading. So see, it shows this really low pressure in your right atrium, higher pressure in your right ventricle, kind of like middle pressure in your pulmonary artery, and then it takes this pulmonary artery or pulmonary capillary wedge pressure. And what that means is they inflate this balloon here. It estimates the pressure of that left atrium, giving them information about your left ventricle, and then they do things with that. I am not going to examine you on any normal numbers for this. I'm not going to examine you on this reading. This is just something that will show up on a board question, and they want you to be able to recognize that this is a pulmonary artery, this little thing that I've circled. This is the pulmonary artery pressures, and this is what a normal one would look like. I realize that that's confusing, and I apologize that I even have to include it, but I just don't want you guys to get burned on the boards because I never talked to you about it. So on my exams, I will not have any questions about the Swan-Ganz catheter, but that is what it is. I haven't seen one in 9 years. My guess is that they've been phased out. What we do now instead is we look for the central venous pressure. So this is measured actually in the vena cava or in the right atrium. It's considered kind of the end of that systemic circulation. We kind of talked about how that's the exit point of systemic circulation because you have that deoxygenated blood coming back from your body into the right side of your heart. The reason that we look at this now instead is it's safer, it's an easier spot, it's less invasive. It is less informative, but that tends to be the way that we monitor patients now is just with the central venous pressure. What the central venous pressure will tell us is what our right atrial pressure is. So that is what we're measuring with the central venous pressure. And again, I'm just going to refer you back to that table on that first slide. This is all condensed in one area. So as you start to get overwhelmed with all the acronyms and all the different pressures, realize that you do have a place where it's all condensed in one area. It takes a minute to kind of get a handle on all the different definitions, but when you do, it really will start to make sense. Okay, so we talked about your pulmonary arterial pressure. We talked about the Swan-Ganz catheter. So now looking at systemic arterial blood pressure, and this should sound a little bit more familiar because it is something you guys do in survey, and it's something almost everybody's had their blood pressure taken for one reason or another. Your systemic arterial pressure is abbreviated as SAP. Its normal is 120/80. The top number is your systolic pressure. The bottom number is your diastolic pressure. So again, we know that the systolic part is during the contraction time, and you can see that would be higher because that's when the heart is contracting down. And the diastolic number is during that relaxation period where the heart is repolarizing. You have something called your mean arterial pressure or your MAP, and the average for that is around 90. And your MAP is kind of like your perfusing pressure. Your MAP is something that is, if you're in critical care, something's going on, we really like to look at your MAPs because this is going to tell us a lot about how adequately your blood is perfusing. And again, we want our perfusion to be adequate because we want to be meeting the body's metabolic needs. Your systemic system is that higher pressure system. So these numbers are higher than your pulmonary arterial pressure because now we're in the systemic circulation. We're talking about a higher pressure system. There's higher vascular resistance. And again, you can just think about that by the fact that you have blood that is leaving your heart, going all around your body, and then coming back to your heart. So it's going to face a lot more vascular resistance just because think about all the areas it has to go. You're going to have thick-walled vessels with lots of smooth muscle. And the reason that that's different than your pulmonary circulation is you have to think about the fact that you have all of these vessels that are going to be like constricting and dilating, trying to kind of guide blood flow to all the areas that you go. And the best way that I visualize this is if you are sitting here and you raise your hand straight up over your head. So many different things in the vessels in your arm and in your hands have to change right now to keep that blood flow going to the tips of your fingers so that you're still getting adequate perfusion to the tips of your fingers. So if you can imagine holding your arm up in the air, or actually just do it, hold your arm up in the air, and you can think about the fact that there's vessels in your arm that are vasoconstricting or vasodilating, depending on where they are, to try to control that blood flow to keep the perfusion adequate in your fingertips so you can still get oxygen to your fingertips and you can still get CO2 out of your fingertips. That being said, if you've ever laid on your arm funny when you've been sleeping, been upside down for a long time, raised your hand for a long time, you notice that you get like tingling sensations or your arm will fall asleep and things like that. This all happens because if you're impeding that blood flow, you can kind of cause like little areas of hypoxemia where it's not perfusing as well as it should. And so you get these kind of systematic responses or symptoms that you notice until it's corrected. And again, it's going to direct blood to all the organs and all the regions of your body. So that's why it's a higher pressure, that's why it has higher vascular resistance, and that's why it has different kinds of blood vessels than your pulmonary system. It's got these thick-walled vessels that can constrict and dilate to alter blood flow. All with the goal of keeping your perfusing pressure adequate. So, perfusing pressure, your mean arterial pressure, your MAP, is normal number is 80 to 100. We really want to target that average around 90, but 80 to 100 is your normal range. If you have a MAP of less than 60, we are very concerned that we would consider your perfusion greatly compromised. We would be concerned that you would be going into organ failure, because if you have very poor perfusion, it means you would not be oxygenating your organs or your tissues effectively. You would not be meeting your body's metabolic needs. So a MAP of less than 60 is very, very low. Your perfusion will be very compromised. Your MAP can be affected by your blood volume, right? So think about some of the patient case scenarios we've done where there's been a lot of blood loss. If you are affecting your cardiac output with blood loss, that's going to affect your perfusion. The other thing that's going to potentially affect it is the capacity of your vascular system. So we talked a little bit about how your venous system carries like 2/3 of your blood volume, and it's really like your capacitance system that can kind of shift blood where it needs to maintain that pressure. If you have something going wrong with that system, or again with blood loss, it can only do so much, that can affect your MAP. You can really think of your MAP as the average driving pressure that creates blood flow. So if you have increased MAP, you're going to have increased tissue perfusion. Decreased MAP, decreased tissue perfusion. The way that we figure out MAP is by taking our systolic pressure plus 2 times your diastolic pressure divided by 3. And that's going to give you your MAP. I will give you guys practice for this, but this is the math associated. So if you go back here, it would be your systolic pressure plus 2 times your diastolic pressure. So if you were using 120 over 80, it would be 120 plus 2 times 80 divided by 3. Okay, that's where those numbers are coming from. Divided by 3. And I'm going to come up with a math sheet for you guys with practice for this. That is how you come up with your MAP. So looking at what controls blood pressure, you're going to be looking at your heart and your vascular systems. So they work together to maintain that adequate perfusion. And again, you're always thinking about just meeting your body's metabolic needs. So your vascular system is going to be your arteries, your veins, your capillaries. Now we talked about with your arteries how they can vasodilate and vasoconstrict to control blood flow. We talked about veins and how they have the ability to kind of have those one-way valves, and they kind of go through a milking motion to control blood flow that way. Your capillaries have those smooth muscle sphincters that can either dilate or constrict to control local blood flow, right? All of these things, all of these systems work together to change the capacity and alter the blood flow in your body, all with the goal of maintaining good perfusion, maintaining good blood pressure, and meeting the body's metabolic needs. Your heart plays a secondary role. It kind of responds to your vascular system. So what that means is if your vascular system if your blood pressure drops for some reason, right? Something's going on with your vascular system where it's not maintaining its blood pressure. What your heart is going to do is recognize that and try to compensate by increasing its heart rate. So if it thinks your pressure is down or your cardiac output is down, then it's going to try to increase the heart rate to compensate for that. And when you think about why that would make sense, your cardiac output is your stroke volume times your heart rate. So you have a volume component to this, like a blood volume component to this, but then you also have a heart rate. So how often your heart is contracting. So they work together to create your cardiac output. So that's how they kind of come together for that. You also have different control factors. So you have local control factors, and that's going to operate without your central nervous system. So when we are talking about capillaries and how they have that smooth muscle sphincter that can either close off more or open up more to control like the blood flow. This would be an example of a local control. So it can alter perfusion based on CO2, acidity levels, pH, or pressure of oxygen. So I'm going to give you an example of where we would see this. So if you have a patient who has severe COPD, whose lungs have been compromised, and they have at baseline shunting, and we know that shunting is having perfusion without ventilation, right? Perfusion without ventilation. So one thing that can happen is in a local area, so imagine alveoli with perfusion going by it, there's not enough ventilation, so it's a low pressure of oxygen is happening there. That capillary has sensory systems that will recognize that it's a low pressure of oxygen, and what it will actually do is close off that sphincter, like vasoconstrict that smooth muscle, which just means to close off. It will stop blood flow from going to that alveoli because it has recognized that alveoli is not providing it with oxygen. And what will happen then is that blood flow will divert hopefully somewhere else where there is good ventilation, a less diseased area of the lung. And what it does is it creates for a better VQ matchup, because the goal is always to have ventilation matched up with perfusion. So if your body has these local controls and it recognizes that, you know what, we're not getting any oxygen here. This is a super shitty alveoli. Nothing's coming through here. So what it'll do is it's going to shut that blood flow off to that alveoli, and it's going to send it to an alveoli that's hopefully participating in gas exchange well, so a not as diseased portion of that lung. So that's an example of a local control. You also have central controls. So you have your sympathetic and parasympathetic system. These are going to respond to a variety of things. Different hormonal agents, nerves. So direct innervation just means when nerves are connected together. And it can control like the vasomotor tone, which is the ability for vessels to constrict and dilate. It's going to have big impacts on your blood pressure. It primarily is able to control like those high resistance arterioles and your capacitance veins. And the reason why is your capacitance veins are what is holding a large portion of your blood volume, so it can help to shift that where it needs to go. And then your high resistance arterioles, because those are really vascular with lots of smooth muscle, and they can vasoconstrict and vasodilate very easily. So if they vasoconstrict, you're going to be increasing blood pressure. So sometimes with like blood loss, like extreme blood loss, it can be really difficult to get any labs or things like that, because your vessels will vasoconstrict. They almost clamp down, and they're doing that because if they make themselves really, really small, they can try to increase that blood pressure despite the fact that your blood volume is low. And that's the goal, is always to maintain that blood pressure. So that's an example of how your central nervous system would be responding to blood loss, is by vasoconstricting and trying to maintain that pressure despite having a lower blood volume. And, again, we're going to talk this through in class in more detail. So hopefully if you guys have questions after listening to this, we can kind of chat about it. So when you're talking about that central control of blood pressure, you can look at your autonomic nervous system, which are those responses that you don't even have to think about. So there's something called the vasomotor center in the pons and in the medulla, and that's going to maintain that normal vasomotor tone. And when I'm talking about vasomotor tone, I'm just talking about all of your vessels have the ability to vasoconstrict and vasodilate, and that's considered their vasomotor tone. They can open or they can close, right? Your sympathetic nervous system, that's your fight or flight. We're going to talk about that here in another lecture in more detail, but that's going to stimulate alpha receptors to vasoconstrict, and it's going to send out epinephrine and other hormonal agents to cause vasoconstriction. And we'll talk about why when we look at neurocontrols more in detail, but I just want to highlight that these are things that all come together to try to maintain an adequate blood pressure, because our goal is to keep meeting the body's metabolic needs no matter what's going on. The other thing that you have are things called baroreceptors, and baro just means like a stretch receptor, or it responds to pressure, changes in pressure, but primarily I like to think about it as a stretch receptor. And these are located in the walls of your large systemic arteries, so your carotid and aortic arch. So if you think about the heart picture, and it's got the aortic artery, which you guys are familiar with, and at the top there's those 3 little notches. So in that large artery, there are these baroreceptors, and what they do is they respond to blood pressure by stretching. So if you're hypertensive, if you have hypertension, you have a higher blood pressure, that's going to increase the stretch of that vessel, and that's going to send a signal to your central nervous system. And what it will do is it will cause this vasomotor center to dilate your vessels. So if you think about why would it want to dilate my vessels? So if you have a high blood pressure, right, your pressure is too high, and it's recognizing that. If it dilates your blood vessels, if it makes them bigger, it will kind of reduce that pressure. It will relieve that pressure a little bit. And then your cardioregulatory center is going to slow down your heart rate, and hopefully then your blood pressure is going to maintain. Because again, the whole goal of all of these systems coming together is to maintain a normal perfusion, maintain a normal blood pressure. So if you're hypertensive, it's going to want to kind of calm everything down by vasodilating to lower that pressure, slowing that heart rate to lower that pressure so it can maintain that perfusion. If you're hypotensive or you have hypotension, it's going to recognize that there's less stretch. It's going to send a signal to your central nervous system. And what that vasomotor center is going to do is it's actually going to vasoconstrict those vessels. So we talked about that. It's going to make those vessels smaller, which is going to increase that pressure. And then your cardioregulatory center is going to increase your heart rate, and it's going to try to maintain your blood pressure that way. Because again, the goal is always to maintain your blood pressure, keep that perfusion going to all of your organs and tissues so it can meet your body's metabolic needs. This is something that I think is really interesting. You guys do not have to memorize this whatsoever, but it's an interesting thing to kind of see the way that your body responds to something. So if you have 10% blood loss from an accident or whatever you have going on, the way your body is going to recognize this is through this kind of process. Your central venous pressure is going to decrease. And you think about your central venous pressure, that's the pressure at your right atrium. So this is where all of the blood is coming back from your body into your right atrium. So your central venous pressure is going to decrease. You're going to have less stretch to those baroreceptors. They're going to recognize there's less blood here, less pressure. Your medullary center is going to increase your sympathetic response. That's your fight or flight response. It's going to increase your heart rate. It's going to release this vasopressin hormone, which is going to cause vasoconstriction. And it's going to be able to maintain or compensate and make sure that your blood pressure and your perfusion are still adequate. At 20% blood loss, same thing. Your central venous pressure is going to decrease even further. You're going to have even less stretch to those baroreceptors. Your medullary center is going to send more of an increase, a signal increase from the sympathetic response. You're going to have more vasopressin. You're going to increase your vascular tone by constricting your capacitance vessels, which is going to shift blood back into your arterial system. And it's going to try to maintain that blood pressure and perfusion. And when you get to this greater than 30% blood loss, this is where you start to see a really big problem. Your central control mechanisms are going to take over. You're going to have a massive vasoconstriction of all of your vessels. So try to imagine all of your blood vessels clamping down, trying to create blood pressure despite large volume loss. It's going to try to, the local controls and the vasomotor tone is going to try to shift blood towards your heart and your brain and prioritize those areas. The increase in your CO2 and other acids are going to override your central control, because remember, we have that local control as well, right? So you have two control systems kind of that are happening at the same time. So you've got the central control that's trying the best it can to maintain your blood pressure despite the fact that you have huge volume loss. And then out in your tissues, because you're not having good gas exchange because of this volume loss, that increase in CO2 and other acids are going to cause vasodilation. They're going to almost do the opposite of your central control. And when this happens, basically, you have the onset of what's called irreversible shock. Your body just cannot. It's to the point where it's too much blood loss. It cannot make it happen. It cannot maintain your blood pressure. And this is a serious situation where if you couldn't correct this very, very quickly, you would have a patient die. So this is kind of the process by which your body really works hard to compensate for any sort of blood loss, and how those systems all come together. So for this one, you know what, honestly, I'm just going to tell you that for this one, there's not much you need to know. Originally, this used to be something that I went into in detail, but I'm not going to do that. Yeah. Well, I do highlight here that vasopressin, yeah, you know what? No, I'm not going to do it. I think that for where we are in the COVID curriculum, this is not something that we need to do. The only thing I'm going to point out is that your kidneys, if you have low blood pressure, will try to vasoconstrict and reabsorb water. If you have high blood pressure, they're going to try to release sodium and release water. And even that, no, forget it. Forget this kidney slide all the way around. Your kidneys do play a part in blood pressure, but as I'm rambling on, I don't think we're going to get into it. So right now you can just mentally put an X through this. This application I just don't think is super helpful for where we are. So we're just going to X this guy out. All right, hemodynamic changes in pathology. So what this is we're going to look at all of those pressures on that handout that we talked about and try to figure out what could be going on in the body. So if we're talking about hypervolemia, which just means high blood volume, you are going to see the central venous pressure or the right atrial pressure be higher than normal. And you can look at that handout that has all the normal pressures on it. You'll see your pulmonary arterial pressure be higher than normal, your pulmonary capillary wedge pressure be higher than normal, your cardiac output will be higher than normal, and your MAP will be higher than normal. And if you think about why this would happen is if you have hypervolemia, it means you have a higher than normal blood volume, so it's going to increase all of these things. Okay? Hypovolemia, so having a lower than normal blood volume, you're going to see all of these numbers be lower than normal. Your CVP, your PAP, your pulmonary capillary wedge pressure, your cardiac output, your MAP, all are going to be lower than normal because you don't have enough blood volume. We are also going to look at left ventricular failure. So after you get done with this lecture, I put in a heart failure PowerPoint. So that's really where we're going to dig into this. So I'm going to just do a real quick brief one because I know this recording is getting long and you're probably over it. For left ventricular failure, if you were looking at analyzing the different pressures of the heart, your central venous pressure or your right atrial pressure would be normal. Your pulmonary arterial pressure could be high or it could be normal. But the two that you would absolutely see be affected with left ventricular heart failure is your pulmonary capillary wedge pressure would be increased. And the reason it's going to be increased is this is the pressure that is reflective of your left ventricle. So you would see this pressure increase because it's showing you that this is failing. And we'll talk about why that would increase the pressure in the next PowerPoint. You would also see your cardiac output be lower than normal because if your left ventricle is failing, it's not going to be able to eject a normal amount of blood into your body. So your cardiac output would be lower. Your MAP could be normal or low. What I'm going to tell you is on an exam, and we'll practice this and you guys will see the application of this. On an exam, if I want you to tell me that it's left ventricular heart failure, these are the only two numbers that I will make wonky because I feel like it's confusing if I start making these maybe normal or high. So the reason I have these highlighted is I'm going to be very, very clear. If I want it to be left ventricular heart failure, this is going to be high, this is going to be low. I'll make everything else normal because I want you to be able to just really differentiate that that's left ventricular failure. And this is not cardiac diagnostics. We're not going to go into detail in this particular class. More than that. Right ventricular heart failure, you would see an elevated CVP or right atrial pressure. And again, if you think about why that would make sense, if your right ventricle is failing, you're going to see an elevated pressure in your right atrium because your right atrium is going to be kind of reflective of your right ventricle. So that's why your CVP, your central venous pressure, or your right atrial pressure will be increased in this. For PAP, I don't have anything for you. For MAP, I don't have anything. The second number that I will make low, I won't even make it normal. I will make it low because, again, just really trying to drive it home, is your pulmonary capillary wedge pressure. And the reason that you would see that low is because if you make your right ventricle fail, that means it's not going to be able to eject as much blood into your lungs, which means not as much blood will come out of your lungs into the left side of your heart. So it's going to affect this pulmonary capillary wedge pressure by reducing it, because you're going to have a lower blood volume on the left side of the heart. And then your cardiac output's going to be lower, generally speaking, because of that. So for this particular heart failure, the big one here is that your central venous pressure is going to be increased. And then when I'm doing it on an exam, I'll make sure these two numbers are also decreased, because I'm not trying to trick you. I want to make sure it's really clear. So that's where you can look at here. I have this handout again at the end just to really drive home that this is something you're responsible for. These are your lecture questions. And if you follow this lecture with like the next one with the heart failure, I feel like it helps to kind of solidify all these concepts together. I know this is probably one of the tougher lectures of the whole unit. So just know that we will circle back and I will give you guys a lot of patient key scenario examples of this particular lecture so that you know exactly how that's going to be applied, and I'm very clear about the expectations for what you need to know.